Imagine a 53-year-old man presenting with chest pain and ECG changes consistent with STEMI. After initial treatment, he develops CHB with a heart rate of 45 bpm but remains stable. This scenario highlights the importance of recognizing CHB as a potential complication of inferior MI and tailoring management based on the patient's clinical status. Key concepts: inferior MI and CHB. An inferior MI typically affects the right coronary artery, RCA, which supplies the atrioventricular, AV, node. This can cause transient ischemia of the AV node, leading to complete heart block. Importantly, CHB in inferior MI is often transient and self-limiting, as the AV node usually recovers once the ischemia resolves. Clinical stability. In this scenario, the patient remains hemodynamically stable, no signs of shock, such as hypertension or altered consciousness. Asymptomatic, alert and without symptoms like chest pain or syncope. This indicates a low risk of progression to asystole. Conservative management. Since the patient is stable, no urgent intervention like pacing is required. The heart block may resolve spontaneously as the ischemic effects on the AV node improve over time. Monitoring is the primary approach. The patient should remain on cardiac monitoring in case the block progresses or symptoms develop. Why pacing is not needed in this case? Inferior MI. CHB in inferior MI is typically localized to the AV node and resolves once reperfusion improves blood flow. As the patient is stable and asymptomatic, pacing is unnecessary. Contrast with anterior MI. In an anterior MI, CHB often involves damage to the distal conduction system, His-Purkinje fibers, which is usually permanent and does not resolve spontaneously. Therefore, CHB in anterior MI has a high risk of asystole, making temporary pacing the standard intervention. Additional points. When to consider pacing in inferior MI. If the patient develops signs of shock, heart failure, or syncope. If the CHB progresses or is associated with non-inferior ischemia or worsening symptoms. If there are risks of asystole, such as very slow ventricular escape rhythms. Atropine. Atropine can be used if the CHB leads to symptomatic bradycardia. However, in this patient, atropine is unnecessary since he is asymptomatic and stable.